I am Ira Kirschbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have the great pleasure of having two incredible guests and honored faculty, Sam Labib from Emory and Jim Nunley from Duke. Um, I would like them to introduce themselves first. We're going to be talking about perioperative control of pain for foot and ankle surgery. Sam, why don't you start and just give us an introduction, even though I feel both of you need no introductions.
You're very kind. Thank you for having us and having me. So yeah, I trained at McGill up in Montreal, did my foot and ankle fellowship with John Gould, and then I joined Emory 26 years ago, and I've been there since. So, and I do everything in the foot and ankle,
Right.
or at
Absolutely.
least I think I do everything in the foot and ankle. Yeah,
There's some things that you don't want to do.
exactly. Yes, sir.
That's good. That's good. And James Nunley?
Yes, so as you said, my name's Jim Nunley, and I'm at Duke University. I went to Duke undergraduate school, and then I got my MD degree at Tulane University. I did, in the old days, you had to do 2 years of general surgery before orthopedics. So I did 2 years of general surgery at UCLA, and then came back and did my residency and a hand and microvascular fellowship at Duke. I joined the faculty, and I restarted the foot and ankle program after Leonard Goldner retired. And I started having fellows in 1990 and have successfully had fellows ever since. In fact, we take 4 a year. So
Wow.
I used to do everything in orthopedics, total hips, knee scopes, all that stuff. And I only do foot and ankle for the last, well, since 2012. So that's my love now.
That's your love now. It's good. And do you have any children in orthopedics, Jim?
Is that a setup? The
That's a
answer is
setup.
yes.
That's a setup. Yes.
I'm lucky. I have 3 children. I have 2 boys and 1 daughter, and both of my sons are orthopedic surgeons. One of them is on the faculty at WashU, and he does total hips and total knees. And I said he went to the dark side, and the other
Yeah.
son, he doesn't operate on people. He operates on animals, and he did his residency in orthopedics in New York, and he's the smart one because he gets paid cash, and he
Yeah.
doesn't have to deal with insurance companies.
There's no orthopedic.
Uh,
There's no orthopedic pre-authorization on golden retrievers, right?
That is correct.
oh yeah.
Good. So, what is the let's talk about the nature of the type of operations that cause pain in the foot and why is foot pain so common to be used as in studies? I mean, what is it about the foot that get that pain and foot come together so much in discussion?
Well, you're right, because the model for any medication for the FDA to prove that it is safe and efficacious has to use 2 models. One is the bunion and the other is the wisdom tooth. And both of those have been deemed for years and years as painful procedures that will require some type of analgesic. So no matter what type of drug you're using, to get it approved, you have to use one of those two studies. And I think the reason I've had my wisdom tooth out, and I'm not sure how painful that is if you don't get dry socket. If you get dry socket, that's pretty painful, but I didn't find that so bad. But bunion surgery, probably because that's the farthest place from the heart. And so most people are not weight bearing immediately. So there tends to be swelling, and the foot is endowed with a lot of sensory organs, not quite as many as the fingers, but the toes have quite a few. So it doesn't surprise me that people who have lower extremity surgery have pain. Sam, what do you think?
So I like to say that the foot is a challenge because it's a complex structure, 26 bones, 5 nerves, and many, many joints. It is dependent, and with that comes swelling and comes, the pain of swelling, and the blood supply and the healing capacity of the foot is a challenge. So you operate on a foot, you can operate on many bones supplied by many nerves, and then you take that structure and it's dependent and it takes time to heal, and that makes it a painful proposition for a long time.
What is currently um the well, sorry, historically we always use opioids, of course, but what is a current model, Sam, now when you're approaching let's say a triple arthrodesis or a
Yeah,
significant case. I'm not talking about a hammer toe, which is
sure.
I'm sure quite painful, but let's take something like a triple arthrodesis or something like that. And what would be your protocol now in going in?
Yeah. So I want to start by saying that 95% of what I do, complex or not, is an outpatient procedure at this point. Okay. And I am a believer in multimodal, pain protocols. I am a bigger believer in, regional blocks and its efficacy. And I have a protocol whereby my patients receive, pain medicine and NSAIDs and a variety of, agents preoperatively, intraoperatively, and postoperatively. And we've been very successful in controlling their pain, sending them home with a long-acting regional block, popliteal block, and they are happy, and pain is controlled for 2, 3, and sometimes 4 days. So I've been very blessed with good blockers, good regional blockers in my program.
And what are you using for the regional blocks?
So we use Exparel,
Mm-hmm.
liposomal bupivacaine, and this has been very effective for us. And actually, it's becoming a little bit challenging to use Exparel at Emory. So other agents have been used, but I don't find them as effective.
Interesting. Jim, what about your protocol in the last 12 years or longer?
So it's very similar because Sam and I have believed for a long time in multimodal pain control. So every patient that I operate on gets Celebrex 2 days before, the day of, and 2 days after surgery.
Okay.
Um, every single patient gets on the day of surgery 1,000 milligrams of Tylenol, and they get put on 1,000 to 1,500 milligrams post-op every day. And I'm also a big believer. We've done a lot of the studies that got Exparel approved for peripheral nerve blocks. So even though it's off-label, we'll still do ankle blocks. We don't always do pop blocks, but certainly with the bigger surgery, you ask about triples, total ankles, TTC fusions, all of those are going to be a pop block. Down in the foot, we have no problem with using Exparel for big toe fusions, which is a little bit more painful than a bunion. With the bunion, we may just use bupivacaine with a nerve block at the ankle. So big believer in perioperative, regional anesthesia. The other thing that we do is every single patient gets vitamin D.
Okay.
I use 50,000 units of vitamin D preoperatively and for 3 months in every single patient because 80% of Americans are vitamin deficient. And
Yes.
vitamin D, we've published on it. It's involved in tendon healing, nerve healing, not just bones. So I'm a big believer in everybody getting vitamin D. Everybody gets a nicotine test if they've ever smoked. And if they smoke, they don't get surgery, period. Because nicotine reduces blood flow, and we think that causes more postoperative pain. So I used to say 10, 15 years ago, I live in North Carolina. If I didn't operate on smokers, I'd be out of business. Well, I'm not out of business, and we make them stop, and we test them before surgery to make sure they're nicotine free before we proceed with any foot surgery.
Yeah. I cannot agree more with vitamin D. I also used vitamin D extensively, and many studies have shown that a lot of Americans and Western societies are vitamin D deficient, and that affects everything. Affects everything. I give vitamin D liberally, and I test it all the time. Yeah.
So, Sam, do you use gabapentin? I know a lot of people use this postoperatively for pain. We've used that occasionally, but not on a routine basis. I usually
Yeah.
give patients postoperatively 10 tablets of Percocet, and it's amazing they almost never use it, but that's the maximum I'll ever give. But a lot of people do use gabapentin. Do you have experience using that?
So we have used gabapentin at Emory, and actually there was a study done comparing gabapentin versus no gabapentin in ACL surgery, and there was no difference. So I reserve gabapentin for patients who had history of chronic pain. I give it to patients that I feel may have CRPS, complex regional pain syndrome, and I like to give those people gabapentin and vitamin C, 500 milligrams daily for 6 weeks. And that has been effective in reducing that, hypersensitivity, if you will.
What do you think is the connection between the amount of acute pain you have and transitioning to chronic pain in foot surgery? Is that a big issue?
So chronic pain, by the way, can be multifactorial, as you know. So we now know that patients who had opioid use had history of chronic pain, for a year or more. Patients who are depressed, has an anxiety, females, all that can lead to more chronic pain. And one of the biggest red flags that I have is when patients come to my office, requesting opioids on the first visit, and I know that they've been on opioids for a year or two. That is a big red flag for me.
Yeah. Jim, what's your experience with the gabapentin?
So I haven't used it so much in the foot and ankle, but my wife uses it, and she has a terrible degenerative disc disease of the lumbar spine. It's not primarily radiculopathy, but it's stenosis, and it's very effective. So I have no hesitation to give that to patients, but I don't do it on a routine basis.
What is the dosage you use, Sam, for gabapentin?
So if I do give gabapentin, I give 300 milligrams QHS at night.
Yeah.
And I tell my patients, this will help you sleep. If you feel, foggy or tired, this gets better within, a week or so. And I have used it, as I said, in some specific patient groups, and I give it once a day.
All right. We have a question from Ahmed Mahmoud. Ahmed, you want to show us your video and ask your question, or I'll ask your question for you? Okay.
Please ask, sir. Thank you.
Yeah. So you have a question?
Yes. My question to Dr. Sam, in your experience, which elective foot and ankle surgery that you will be concerned much about post-operative pain control? Like all the ankle and foot surgery should be painful, but when there is like a do you have a specific surgery that you were very concerned after regarding post-op pain?
So the bigger the bone procedure, the bigger the pain, at least in my experience. So I am concerned about fusions of the ankle and the hind foot. I am concerned about ankle replacements. I am concerned about ligament stabilization of the ankle, and the forefoot or the midfoot. With blocks and with multiple medications, the multimodal has been more and more effective in controlling that pain. But I worry about the hind foot.
I'd like to ask a question. Hi.
So,
I practice in New York City, and I know Ira for a long time. I practiced in the Bronx and have under Ira and have seen a lot of very difficult pain patients, especially and the smokers and the drug addicts and you name it. I've switched my practice to a heavily minimally invasive practice, specifically bunion surgery. I combine that with Exparel now. I've got to tell you that patients really have almost no pain post-op. Of course, it's not a guarantee, but it's between the tiny incisions, the non-degloving of the soft tissues, so to speak, and keeping the soft tissues kind of minimal. And the use of Exparel, I mean, I give out my cell number to patients and they never call. I mean, the only time somebody will call if their zip code is 90210. But other than that, like, people are very, very comfortable these days.
And what blocks do you use with Exparel? What do you use it at the ankle level or where?
Yeah, so generally, again, most of it's bunion surgery. I'll do an ankle block, but anesthesia tells me I suck at it. So what happens is that now, they make me do a more of an ankle block, but really getting the deep perineal sort of at the midfoot level. That seems to really make a difference. But in terms of the Exparel, I think what's worked is after the surgery, if it's 1 foot, and I do a lot of bilateral surgery, if it's 1 foot, I'll use all 20 milligrams of the Exparel. And I'll do the first 10 is just incisional and subcutaneous. And then the other 10 I'll do is more as the Mayo deeper block and also get ankle. And then when I'm doing bilateral, what I'll do is I'll add in, I'll just do 20 with 20 of saline. Depending on the size of the patient, I may add some Marcaine into that mixture as well. But I'll tell you, this has been a game changer, and I'm still not sure. And by the way, bunion surgery hurts, right? It hurts. I mean, and I'm sure you've all been in practice and done your fair share of bunion surgery. But one of the reasons people never go through with getting their other foot done is because it hurts so much. Well, this is gone with all this minimally invasive surgery, and just want to know if anybody has any of that same experience from that regard.
Jim, what do you say?
So I have the same exact experience, but I don't do any MIS, but I do a Lapiplasty. And I think that with immediate weight bearing, a day of surgery or a couple of days afterwards, and with an Exparel ankle block, they have no pain. They don't take pain medication. I have a partner who does all MIS. I have a couple of partners that do all MIS. So I'm not against it, and I absolutely agree with you that there is less swelling, which clearly would relate to pain. But I'm also impressed with the fact that with stable fixation and immediate weight bearing, your pain is greatly reduced, greatly redued.
And you're saying that for both a Lapidus or a minimally invasive, or just
Yes, yeah,
in general?
yes. Yeah, but I think that with the MIS, you clearly have less tissue dissection, less swelling postoperatively, and you probably walk them weight bearing right away, the same as we do if you do an open Lapiplasty.
I can see how if you don't disrupt the soft tissue envelope, you have less pain for sure, yeah.
So Ira.
Yeah, Kevin Blanchard. Yes.
Hi. Can I take it back a minute?
Yeah.
So we in New York City, I'll speak for a lot of us, absolutely use Exparel, you know, on total knees and lower extremities and blocks. Curious, do they do blocks? That's now indicated, one. And two, is your cocktail, if you're doing a periarticular injection, mixed with other things? So we don't use Exparel on label with Exparel. So there's a lot of wonderful other chemicals that we're not allowed to use on label, but we do because we now, since the competition is coming out with 30-day pain relief and stuff of that nature, do you mix it with others? Is it just straight up like a gin and tonic? And do you do any blocks, you know, personally, not anesthesia, in the popliteal block, or what do you do? I'm curious to hear.
Let's start with Sam, go to Jim, and then we'll add anyone else. We'll add Neil, we'll add Ahmed. Let's start with Sam.
So, you know, if you're trying to do a block for the knee, I think IPAC, which is, you know, placing Exparel in the back of the knee plus an adductor block has been effective, right? And if you want to supplement that with peppering or intra-articular, you know, injections, Exparel also works well there. I'm not familiar with other, you know, medications that you can add to Exparel. I mean, Exparel got approved in the popliteal block for 4 days of pain relief. So I'm not familiar of medications that would last, like Kevin was saying, 30 days or whatever it is. Not familiar with that.
So we always mix Exparel with bupivacaine. And so that means because we want to have a motor block that happens faster. And so that's what lysosomal bupivacaine is. So if you mix them and use that as a pop block, then you get the immediate motor and sensory block, and then you get the prolonged postoperative block. And Kevin, all of our blocks are done by anesthesia. And even though it's off label, they'll still use the ultrasound, and they'll do the ankle blocks, certainly the posterior tibial nerve, and then they'll do the other nerves just subcutaneously with Exparel mixed with bupivacaine. So I personally don't have experience. I never liked the peppering technique. That to me was just too much trauma, sticking that needle 20, 30 times in these little wounds. And so I held off until we could get a block that was what I consider to be effective. And yes, there are other companies that have medications that are actually compounded, but I personally have no experience with that. I don't know if anybody else here has experience with them.
Right. Let's I think Abshan Malik, you want to unmute yourself, ask your question? You have a question there, Abshan?
Yes, just wanted to ask if anyone on the panel had any experience with Zin Relief. It's basically a combination of bupivacaine and meloxicam, and we used it just prior to closing the incision for pain management.
In what joint, Abshan? It doesn't.
Well, lapidus, first MPJ, just pretty much even ankle. It's the only downside we found is it's very sticky and gooey and kind of gets stuck to your gloves. So it was the last thing we did prior to skin closure. And patients usually had pain relief for up to 5 days, absolutely no pain, and they took nothing else besides having that.
That certainly is what they talk about when they give the lecture. I've tried it on the sawbones, and it is gooey, and you got to keep it in the subcutaneous tissues. So I've heard good things about it, just have no personal experience.
Sam, any experience?
I don't have experience. I'm aware of it, but I don't have experience with it. It's not approved at Emory. And, I heard the lectures. I did use it on, in a cadaver lab, but did not use it in practice.
Neil, have you used it, Dr. Blitz?
I have not, no.
No, okay. Abshan, tell us more about.
So Kevin, tell us what's this 30-day drug? I'm fascinated to hear that.
Mm-hmm.
Where did Kevin Blanchard go? He quit?
You see him?
Oh, maybe he looks frozen there. Yeah, I think.
Can I maybe move to a topic, if you don't mind, that I think
Go ahead, Neil.
hear from some of the experts here. we started to talk about chronic pain, and CRPS is probably one of those things that we're all terrified of. It's so nebulous, and in fact, anybody can get some sort of lawsuit based on CRPS. It's very hard to diagnose, and and so we always look at things to try to mitigate that. And one, from a record keeping standpoint, and two, what things can we really do to try to, of course, identify it early, which is probably the key to that. And I guess what I'm going to bring up is for patients who are getting a general anesthesia, especially, are we doing local incisional or local blocks in addition to sort of mitigate that pain response that some might feel? Because, just thinking of being on the stand or, saying, did you do a local block before you did the general anesthesia? Because the pain is still being transmitted. So just get thoughts there. And two, what other really modalities can we do as providers to really arm ourselves against the unscrupulous CRPS diagnosis?
Yeah, who wants to take that on first?
Well, first, I think CRPS is incredibly rare, and we've done a lot of work with it. I think there are definitely ways to make the diagnosis. We use a cold stress test to see if they have a sympathetic response, et cetera. There's a whole host of literature on this, but I think that the majority of people who have these chronic pain have identifiable reasons for their pain. And before I label them and send them to a pain clinic, I think you need to pursue every single avenue to find out exactly what it is. Do they have a compression nerve injury? Do they have a partial nerve injury that occurred like when you do a bunion and you catch a little bit of the branch of the dorsal nerve? This can produce a chronic pain type syndrome. So I used to see a lot, and I see almost none now. And I think with the techniques that we, first of all, your question about the general anesthesia, we don't do anything under general, but it's interesting. All of the total knees are done under short-acting spinals with an adductor block. And so you want to stop the initial pain response. That's what you're alluding to. Mm-hmm. If you can stop that from happening, then theoretically you can reduce the postoperative pain response. So when we do our total ankles, all of them are done under pop blocks. But we also lots of times use an LMA, and that's after the block has been put in an hour before surgery. So our blocks are put in another room. They're allowed to set up, and then they come back, and usually we use an LMA or never a general unless they have some airway problem. But yeah, I think that makes a big difference, at least for me.
Sam? Let's hear from Sam.
So, yes, sir. Our protocol is to use regional blocks for 95% of our patients, and we do an LMA, anesthesia, which is what I describe as, anesthesia light, if you will. And I think the regional block does the trick of patients getting, postoperatively minimal pain relief. And that now is lasting 4 days with the combination of liposomal, bupivacaine, and bupivacaine mixed together. And our folks do a popliteal block and an adductor block, for any hindfoot surgery. This has been very effective. I agree with Jim that CRPS is not as common. But if you have somebody that comes to your office with severe pain, history of narcotic use, multiple surgeries, hypersensitivity, all that, then that should raise red flags. And I get pain medicine evaluations on these folks before I do any surgery.
Interesting. Jim, just two questions.
So let me just give an example of a case.
Excellent.
So just recently saw a veterinarian who was about 40 years old that was carrying the diagnosis of CRPS and had an osteochondral lesion of the talus. And so this was microfractured. and that didn't do well. And then there was another arthroscopic procedure. And then the patient had an open medial malleolar osteotomy with an allograft. And she couldn't work. She had a big swollen foot, chronic pain. So we investigated. And so she had lumbar sympathetic blocks, and that gave her some temporary relief. But we did electrical studies, and she's got tarsal tunnel. We also did a block of a superficial peroneal nerve at the ankle, which had been injured with the arthroscopy, and that dramatically reduced her pain. So we went ahead and did her surgery under a regional block to get a long-acting sympathetic block. We decompressed the tarsal tunnel, we decompressed the superficial peroneal nerve, and did an ankle fusion, and she's done great. She'd been in chronic pain for 4 years. I'm telling you, you look for causes that you can correct before you give up on them and send them to a pain clinic is the plea that I would make.
And I cannot agree more. I mean, I'm not writing people off, and sending them to pain medicine easily. But, when I worry about their response to pain or a long history of pain medicine use, I actually have an excellent resource. These folks will see patients and manage them post-operatively with us. But I agree with Jim. I mean, if you can find an anatomic, reason for their pain, then you are likely to help them the most.
Yeah, and again, just to follow up on that, thank you. I think those are all really great points. Do you have the patients who have CRPS in advance of a procedure, which it sounds like, again, I totally agree with those sense. Then you have the people that are normal. Normal is a strange word, but that don't have CRPS but have a surgery and then therefore start eliciting symptoms of that. And so again, I just get back to that sort of other question is like other modalities, for people that don't have CRPS, like vitamin C, are there any kind of tricks is really what I'm getting at that might really just help us maybe move the needle a little bit more towards not going down that unfortunate pathway. And I don't have a ton of CRPS, by the way, just
Just personally. Yeah, right.
yes.
Well, what I would say is that I would look at them carefully. I would put them on gabapentin. I'd make sure I did everything to control swelling. Swelling, is a big contributor to pain. And so if you can use Uniboot wraps and some of these other techniques to try and reduce the swelling and get on it early, but not with narcotics. We have data that shows that 9% of orthopedic patients that are put on narcotics for postoperative pain ended up being addicted. So we don't want to have that happen.
Right. So I want to point out, Jim, that I think Kevin's on right now. So you had a question for him about.
Yeah, Kevin, what's this medicine that lasts 30 days?
Yeah, no. 1 second. I want to just first finish to say that Exparel has changed my life, liposomal bupivacaine. I am not a consultant. I want to make it very clear. And 9 years of total knees that outpatient before we were allowed to do it outpatient. I love disregarding rules. People were sent home because of liposomal bupivacaine. So I want to make the statement that I'm so excited about foot and ankle. I would say Andrew Wickline is someone you all should follow in terms of edema control and swelling. He's written a tremendous amount about new thoughts about it, and he's really brilliant and has made it his life cause. So if you do have swelling and things, please search out Andrew Wickline. He's much smarter than I'll ever think about it, and he's beyond passionate. The 30-day, what I'm saying is there are many companies coming out now with other ways. And so who knows if they'll work, and who knows if it's really good to eradicate pain for 30 days. That's what, I'm sorry, some healthcare providers known as nurses like to do because it's pain management. But maybe it's okay to have a low level, not high level, of discomfort, because when you take away discomfort, you may miss blood flow, circulation, and other things. So I'm just saying I'm happy what we have today in liposomal bupivacaine, but I'm telling you, watch out, there are other things coming, and they may not be additive. So that's why I'm saying it. And I'd love to know if any of you, because I love doing that, is I use anti-inflammatories. As long as we're safe on the stomach,
Yeah.
to decrease swelling, and this business about it impedes healing is just not accurate and left over from old research. So I'm curious in the foot, where it is a big deal, the osteotomies, the Lapidus that Jim talks about, whether it's open or minimally invasive, do you now carry on with other oral supplements to supplement the liposomal bupivacaine?
I'll take a crack at that. So our protocol is patients come, they get, preoperative Celebrex, sometimes gabapentin, and then they get IV acetaminophen during the surgery. They always get a block, an Exparel plus bupivacaine. And then when they wake up, they have another dose of IV acetaminophen and they go home. And once they get back to the house, we tell them, do not wait until your numbness wear off. We start them on Tylenol 500 3 times a day, naproxen 500 twice a day, aspirin 81 milligram twice a day, and a lot of them never use a narcotic. And it has been my experience that by the 5th day post-operatively, the pain is more or less dissipated. I don't know if that's everybody's experience. But I like to tell my patients by 5 days, you have 50% of your pain. By 7 days, you probably have 70% of your pain gone. So this has worked very well for us.
I agree with Sam, except I don't know how at Emory you can afford to give IV Tylenol. We used to do that, and it was so expensive that we give, as I said before, 1,000 milligrams in the pre-op with a sip of water, and it's a whole lot cheaper than giving it to them IV, which, as you may or may not know, is very expensive.
It is expensive. We have a deal on it. I don't know.
I should know. I should know you have a deal.
We have a deal on it. Yes, sir.
It comes off the truck. I get it.
You brought up an interesting point, at least in practice, is again getting back to the things that we can do to help our patients is preoperatively. I mean, so if you're doing an Exparel block and the patients are comfortable, are you still telling them to take all of these medications, the non-narcotic medications, if they have no pain?
Starting the next day, we do. And I think what we're doing is we're modulating inflammation. You see what I mean? I think inflammatory modulation is something that is important. And you can be blocked, but if you develop an inflammatory response to your surgical insult, then when it wears off, you get a whole lot of pain. That's what I think.
The old-time podiatrists used to use podiatrists here, admittedly. The old-timers used to use a lot of steroid injections at the same time of like their osteotomies and stuff to really mitigate inflammation and swelling. I think that's come out of favor for all the negative effects of steroid, but it really probably does go in line with this concept.
As an old timer, get ready for an article. I use steroids now for 39 years, and we do it in every joint that we see for arthroscopy. And I'm excited to report it does help. And I take difference at Stanford, and I know the PKs and I know the pHs, and I am ready to say my cartilage surfaces are fabulous in my patients for 39 years with 20-year follow-up. But I hear you loud and clear. But dogma changes, and as leadership teaches, always doubt what we do.
I want to tell you guys, Eric Wagner and Mike Gottschalk at Emory, published a prospective randomized study last year about shoulder surgery with a Medrol dose pack following the surgery versus no Medrol dose pack. And those who took Medrol dose pack had 50% less pain and opioid use. So there is merit. I worry about it in the ankle and foot, just because of the healing difficulties that we have already.
Jim, what are your feelings? Steroids, you've seen them early in your career, you see them now. What's your feeling?
I tell my patients that if they need steroids, they're going to get a Medrol dose pack. I'm not going to put it into a joint because I do think that it has the potential to harm the joint. And I don't think there's much downside to a very quick Medrol dose pack. So I do not inject it, but I know that's, as Neil said, that's old time and it used to be done a lot, but I don't see it done anymore. Not here.
It's very interesting that Kevin mentioned Andy Wickline. I just want to show everyone an article that he wrote. This is Mitigating a Post-Operative Swelling Tsunami, he called it, in total knee arthroplasty, a call to action. Just to give you an idea how popular this article is, 12,173 views. Okay. 12,173 views. He's running a seminar at ACUS, and he just really believes any surgery, pain is all about swelling. So let's spend a little time,
So what does he, wait a minute, what does he say in the article that he does? Because our knee surgeons now won't send anybody to physical therapy. My wife's getting ready to have her other side done, and they said, you're a couch potato for the next 3 weeks. No swelling, period. No PT, no nothing.
So what Andy does is, first of all, he uses an irrigant by a company called Next Science, called Experience, which actually attacks both the biofilm and is very friendly to the tissue and causes less swelling than other things. So he believes in that. He uses a compression stockings from a company, I believe called Dynamics.
Called Edema Care.
Edema Care. Yeah.
I use it. I've talked at length with Andy, and it has made a big difference.
Yes, the company Edema Care. He uses this special compression device. He has his own exercises, right, Mark?
Yes, and he also has a medicine which is name. I use it, but right now I just can't seem to remember it. You probably know it, Ira. That it's over the counter, and it seems to work very well. And I've been very happy with Andy's recommendations.
Yeah,
I'll find the medicine if I have to think about it. I'm having a senior moment.
It's okay. So we all are. Yeah. Swelling's a big thing. Yeah, have you found good success with the edema protocols?
Since I've decided to talk about something, I apologize for changing. I should have spoken up earlier. My community, we've had, since the pandemic, there's been a huge turnover in our anesthesia people. And I've had more than I care to admit of terms of serious injury from IPAC blocks as well as from complete popliteal blocks. I would say that some of the serious ones did get better, and everyone's gotten better, but in 6 months, and it was a pretty horrifying 6 months having to be talking to people in the middle of the night so often. So don't take it for granted that everyone has the same, that every anesthesiologist has the same skills that Dr. Nunley's anesthesia colleagues have. Right. I come and work for him I work for free for you, Jim.
Yeah.
As long as you said I'm not going to have any nerve complications from blocks. And fortunately, I think we've got a new person who's pretty good at it. But now I don't want to have anyone give a blocker to any of my patients unless I know them personally and I know they know how to do it. And I've also had in the last year 2, thank God they're getting better, but I've had 2 complete brachial plexus blocks after shoulder surgery. Brachial plexus damage after shoulder surgery. And they're getting better, thank God, but it's been a rough season for me.
Well, let me give you a little anecdote, okay? 30 years ago, we got an anesthesiologist that came to Duke, and we had never had regional anesthesia ever. We just didn't. Everything was a general or spinal. And she decided that she was going to change that and start the regional block. And I had the biggest malpractice attorney in Connecticut come to me with an Achilles problem. She did a block on him, and he got a complete post-op foot drop.
That's what I've had.
Complete. And you talk about being nervous.
Yeah.
I sweated this out. And like you said, at 6 months, it started to come back. At 9 months, it was back to normal. It can happen. But I swore at that point, I would never have a block done again. And now, 30 years later, 100% of my cases are done under block with anesthesiologists that don't use let me just see, touch the nerve till it hurts, or let me use the electrical stimulation to see that I'm close and the nerve twitches. They all use the ultrasound. And so you're right. We have a group of people now that have been trained that don't screw up. Thank God.
That's what I need. If you have anybody if you know any anesthesia fellows finishing your place, send them to my direction.
I've had the same experience as you, Mark, by the way. I had one similar case with a popliteal block, and a patient for just an elective bunion surgery had complete anesthesia to the entire front of the leg, was so mad at me. And of course, I did not do it. And it ultimately took about a year to then go down to a small little dime size patch of anesthesia. But it was not worth sweating it out like Dr. Nunley there. I get much more nervous a lot quicker. And I just would never do it with the advent of Exparel now. And it just, to me, it offers no advantage whatsoever.
Just make sure that we trust the person who's sticking in the needle.
Yeah, but you never know. I mean, it's just, again, they're coming in for an orthopedic issue and then they're winding up with a foot drop. I mean, it's hard to, it's that you didn't cause. It's very hard to, it's still, you get named in a lawsuit or you're still part of that process. So I don't know. To me, it's not worth the risk.
I have not been named in a lawsuit for this because I've been babysitting. I've been such a good job of babysitting. But, you know, it's bad for business. No one's going to write you 5-star review and going to set up to get their next total ankle or total hip or total knee as soon as the 90-day period is over, when they've been having nerve pain and they've been anesthetic. I currently have one at 3 months. She is starting to wiggle her lesser toes. She never had a foot drop, but everything else, tibial and popliteal artery and sural nerve, everything is messed up on the EMG.
And I want to make a comment, if it's okay. Yeah. So it is very operator dependent. Those good blockers will come so close to the nerve. I've watched many of them do it. I go to the bedside and I watch, and they have to kind of infiltrate, around the nerve. But I tell my patients, especially the diabetics, I say, if you have diabetes, if you have peripheral neuropathy, there is a chance that this nerve does not recover as fast, okay? Luckily, there is a review of lower extremity popliteal blocks, and 96% of all patients got their feeling back within a year. But that meant that 4% did not.
That's right. And it's still a long year for us if the patient is in that 96%. It's a long year for us. Lots of sleepless nights.
Tell your diabetic patients that they may not recover as fast. That's what I do.
Thank you.
Personally, yeah.
And I want to just also change the subject. Jim, thank you so much for bringing up the subject of CRPS as a garbage can, the big garbage can of I don't know what's wrong, so it's CRPS. Thank you for bringing that up. And it's a lot of my patients, people that have been around to 10 different folks. And I found that by ordering my imaging and also ordering rotational studies, you find lots of people with external tibial torsion or femoral torsion, either in over anteverted or under anteverted, that have been proven, at least in my practice, to be the cause of the problem. So before you start telling people to go to the shrink, make sure that we don't have an orthopedic diagnosis that's right in our line of work. So thank you for bringing it up.
We have just a few minutes left. I want to just pepper a little bit on the concept of nutritional supplements. We talked about vitamin D, talked about vitamin C. Is there a role for some of these perioperative nutritional supplement companies, or is it voodoo? Is it the real stuff? I'll start with Jim, go to Sam, go to Mark, go to Neil. We got our players here now. What about nutritional supplements?
I'm not smart enough to know the answer. What I will tell you is my good friend Bob Santrock, who is now in practice in Florida, has a protocol where he gets the albumin and a few other things preoperatively, and he hands the patient a diet and says, this is what you need to eat. It's not a supplement, it's regular food, and he tells them what they should and should not eat, and he's very vigorous about that. I don't have that sheet, but I know that he swears by it, and I think it's probably a very correct thing to do.
Interesting. Sam?
Well, I'm a believer in vitamin D. I also ask patients about vitamin B because B12 is a problem. Calcium in women has been shown to, also be, needed. And then albumin level. If somebody is malnourished, then they need to have, they need to correct that. Otherwise, I'm not aware of any good science. Supplements.
I think we all know we've seen published the workup, the metabolic workup for non-union, with all the blood tests, inclusive, of course, albumin and vitamin D and everything else. And before I do an elective big surgery, I subject the patients to the same bleeding regimen to get all those tests. And if I encounter something that's not right, I correct it before. Or at least I start correcting it as fast as possible.
So you're referring to thyroxine? Thyroxine
even
level?
Even before one of your external, even before one of your Achilles insertional tendinosis operations that I do that I learned from you.
Yeah.
I even get them.
People are looking at ferritin levels and a bunch of other things to see what their nutrition status is. And I just haven't either been smart enough to buy into that yet or wait for enough data to prove that I need to do that.
And if I don't know what's the right to do with it, I get the results. I don't know what the right to do with it. I'll find a colleague that does too.
Yeah, never order a test that you don't know what to do with the result.
Well, yeah, I would not say I know what to do with it. I just don't know what medicine or what to do, but I send them to the colleague that would know.
Yeah.
But
that's why in our practice, we don't get blood pressure readings in our clinic. I don't know what to do with a 190 over 120. I just don't know.
Well, my cardiologist says it's a waste of time taking blood pressure in the patient in the office, because by the time they get get through the traffic, find a place to park, finally get to your clinic, and waiting a half an hour longer than it should have been, they all have high blood pressure. So they regularly in Houston, they tell you to check your blood pressure twice a day and text or email the office on your on the app, so they can decide whether or not you need a medicine or not. So some people think it just doesn't help.
To respect everyone's time, I want to sum up. I'll start with Neil. Neil,
I just wanted to add, just on that nutritional component, you guys spend way too much time with your patients. I mean, I'm not finding out about their eating habits. I look at them and go, can we do this surgery? And I'm not, the max I'm doing for everybody is it's vitamin C. And again, I'll quote somebody famous. I mean, I'm unemployed if I'm not in the room or in the operating room or seeing a patient. So, I mean, I don't spend the time, and I'm not saying I'm not an insensitive doctor. I just don't feel it's my place to be, really going into the nutrition. I'll give my hand out and say, do this. And then I think when they don't heal, again, we're not talking about diabetics, right? But when they don't heal, that's when you start asking the question, like, so anyway, I think I need to spend some more time talking to patients.
Consider asking it first before it hits you right before you're going on vacation.
So let's sum up. I'll start with Jim. Just a few final comments about perioperative pain and where people should go with it. Then I'll end up with Sam to bring us home.
So I think that everybody here agreed that some type of multimodal anesthesia or pain control is what was needed. I think the consensus was that it's certainly safe to use NSAIDs. And I think another consensus was that reducing postoperative pain with long-acting blocks, regardless of what type of technique you use, is a good idea, and that controlling swelling is paramount in trying to reduce inflammation and pain.
Awesome. Sam, you want to bring us home?
Well, once again, I agree with everything Jim said there, multimodal, but my closing remark is go to the nurses in your ASC or in your surgery center, talk to them about multimodal, talk to them about what you're doing, because they need to be on board. Because if you tell your patients you don't need opioids, and they, before they send the patient home, say, oh, if you don't have opioids, you're going to be in trouble, then you're shooting yourself in the foot. Make sure that your team knows what you're doing and get them all on board. That's my advice.
Well, I'll leave with this comment. And when Neil worked at Bronx Care, we had somebody who was shot someone in the community in the Bronx. I know people find that hard to believe, but they shot him, and they shot him in the foot, and then they shot him in the knee, and then one of the other doctors said he's eventually going to get to a vital organ. And Neil said he already did when he shot the foot.
True story.
A vital organ, yeah.
That's a true story.
Wow.
So I want to thank the signed up faculty, Sam and Jim, and the extra faculty, Neil, Mark, Kevin, Mahmood. If we didn't get to your question, I apologize. And I just want to say thank you to everybody for another wonderful topic session.